Welcome to the Panorama Patient Education Network. I'm Dr. Matt Stern, your host for today's roundtable discussion on neuropsychiatric symptoms associated with Parkinson's disease. I'm joined today by my distinguished colleagues, Dr. Daniel Weintraub, Professor of Psychiatry and Neurology at the University of Pennsylvania and a world-renowned expert on the neuropsychiatric features of Parkinson's disease, and Dr. Rachel Gross. Dr. Gross is a neurologist formerly on the faculty of the University of Pennsylvania's Parkinson's Disease and Movement Disorders Center. She is now a practicing psychotherapist who specializes in the psychiatric treatment of patients with Parkinson's disease. Now, I'd like to start with a discussion of depression because depression is really so common in Parkinson's disease. We all see it. And the thing that's always interested me is that it can occur at any stage of Parkinson's disease, including the very early stages of disease. Dan, what's your take on that?
I agree with you, Matt. I think it's one of the first symptoms that James Parkinson described when he was describing Parkinson's disease for the world over 200 years ago now, and it's probably been the most studied of all the psychiatric conditions. And it is one that's very common and can be disabling for patients. And as you noted already, one of the interesting things about depression is it can actually occur prior to the onset of the motor symptoms, prior to even patients being diagnosed with Parkinson's disease, which makes it meet the criterion for what we call a prodromal or a preclinical feature of Parkinson's disease. Now, why would this happen? Well, one explanation is that the disease pathology for Parkinson's disease may be starting lower in the brain or in the brainstem, and that these are neuron centers in the brain that are crucial not only for eventually the development of Parkinson's disease symptoms, but also for mood regulations. So the nerve centers that are responsible for producing serotonin, for instance, a very important chemical in the brain associated with mood, may be affected very early in the disease course prior to the motor centers being affected.
So you're saying that depression could be part of the disease, or it could be a reaction to the disease, right?
Without a doubt. I think there's both a biological component to depression in Parkinson's disease and a psychological component as well. And that's why you also see an increase in the prevalence or the frequency of depression when patients are diagnosed with the illness, and then moving forward throughout the course of the illness, the prevalence of depression just keeps increasing with time.
And let me turn to you, Rachel. You see a lot of patients with depression. You know, if we're talking to patients and family members, what are some of the symptoms that they might look for that might give them a clue that maybe they have depression and should seek some help?
Right, I would say that sometimes it's not just feeling sad or crying a lot or even something that would feel like I'm down all the time. Sometimes it's more subtle than that, and this could be complicated because it can overlap with some of the other things I think we're going to talk about today that go along with Parkinson's disease, but they may notice that they're just not as interested in the things that they typically are interested in, or they don't get pleasure out of the same thing. So maybe it used to be fun to go to the movies with their family, now it's kind of blah. Things like that, difficulty concentrating, trouble sleeping.
Is this something that the patient will recognize, or is it something you hear more often from a caregiver or a family member?
I think that varies a lot, and that's probably not totally specific to Parkinson's disease, but I think people that come either come because they're noticing these things, but often their doctor sends them, maybe their neurologist will send them, or maybe a family member will start to say, you know, you're just not yourself. And sometimes people don't even recognize it as depression. You know, they'll come in saying, I've gotten this diagnosis, these set of symptoms have come up, I'm not really sleeping well, I'm not concentrating well. Depression is something that they'll come to understand is going on through talking in the therapy.
Yeah, and that's kind of been my impression, that a lot of times patients don't quite acknowledge that they're depressed, and when we as neurologists mistake a lot of their sort of their motor slowing to the physical aspects of Parkinson's disease, and often it's not that. Often it's really depression that can lead to sleeplessness and all the other problems, right?
I think one of the difficult things, and I'm curious to hear Rachel's opinion here, is that there's so much symptom overlap between the core symptoms of Parkinson's disease and depression. So if you look at the diagnostic criteria for major depressive disorder, for instance, it involves changes in sleep and appetite, energy level, slowing, and we also know that those are core symptoms of the Parkinson's disease itself. So how do you tell when symptoms are due to the illness versus a depressive syndrome? And I thought another interesting and important point you made was that one of the symptoms patients sometimes present with is a lack of interest or motivation. And another very difficult part of the differential diagnosis for depression is whether somebody is actually depressed or more likely to be suffering from what we call apathy, which is an amotivational state. And these are very difficult things not only for patients and families to disentangle, but for us as clinicians as well.
Right, and sometimes I don't think they're totally disentangleable. I mean, sometimes with time and talking it through, you can figure out some of these things, or maybe there's both things contributing, but sometimes it takes a medication trial or something like that to try to tease it out. So if an antidepressant or a course of psychotherapy is tried, and the person's doing a lot better, sleeping better, concentrating better, back to life much more, that tells you something.
Yeah, and the other thing I've noticed is that there is a fluctuating depression that can occur in relationship to medication as well. I've had some patients who will tell me, you know, they feel sad as the effect of their medication is wearing off. Have you experienced that? Have you noticed anything like that?
For sure. I think you're bringing up other subtleties and nuances in the mood dysregulation that can occur in Parkinson's disease. We know that once patients have had the illness for some time and have been treated with medications such as levodopa, that they can develop motor fluctuations. That's a very well recognized syndrome. We now also recognize that there are non-motor fluctuations that can occur as well. So those are people, as you just described, that as their medication, particularly their levodopa, starts to wear off after a couple of hours, let's say, they can notice changes in mood as well. They can become anxious, they can become feel sad inside, their thinking can become slower. So they have these fluctuations during the course of the day, similar to the motor fluctuations they experience.
Yeah, and I think it's a very important thing for patients to be aware of. And you know, when we talk to patients and caregivers, we really want to highlight the heterogeneity of Parkinson's disease, and most patients think of this as a motor syndrome, as we talked about earlier, but often the motor symptoms can be well controlled, and it is these other subtle features that we really need to recognize because they are potentially treatable. And as we begin to talk about treatment, Rachel, we send you patients with depression. How do you decide what to do?
That's a good question. There isn't, I think, a one-size-fits-all for people. It depends. I mean, I think when somebody comes first, you know, you find out what brought them, who sent them, did they bring themselves, and what is it that they would like to happen, to see happen. Some people would like to try a medication. Some people are really dead set against a medication and sort of anything in between. It's also useful to know whether depression's been something that the person's had off and on throughout their life, and we're seeing it again, and maybe the diagnosis of Parkinson's has brought it to life again, versus this is a person who's had no trouble really with any mood disorder, and then they've been given this diagnosis, and whatever it means to them has caused them to become
Well, let's
depressed.
stop there for a second, because I think you bring up a really interesting point. I mean, how many of these individuals do you see whose depression, as Dan alluded to earlier, predated their Parkinson's? It used to be said that patients who had a tendency to depression were more likely to develop Parkinson's later on. I mean, is this something that you see?
Yes, I mean, it's not uncommon for that to be the case, but certainly I have people that I see who really don't have a history of any mood disorder at all, and they've been given this diagnosis, and whatever it sort of, again, as I said, like whatever it means to them, or whatever limitations it's causing, that's the thing that's kind of prompted the change in the mood. So I've seen it both ways.
And that sort of underscores what you said. That's kind of the reactive depression that you hear.
Right, and I wanted to hear from Rachel as a psychotherapist. This has been my impression as a geriatric psychiatrist in the past, having seen Alzheimer's disease patients as well, is that one of the things that I think really distinguishes Parkinson's from Alzheimer's disease is that you have a much more variable age of onset. You have many people with their onset in their 50s or low 60s, which is unusual for Alzheimer's disease, which means often these patients are still working, they're raising families still. And my impression is that Parkinson's disease can be a much more disruptive illness to people's lives because of the stage of life when they first have their onset. And I was wondering if you had that experience working in psychotherapy with patients.
Yeah, I think I would agree with that. Some of the the younger patients, people in their 50s, 60s, even in 40s sometimes. I mean, first of all, there's a sense that this is not supposed to be happening to me at this time of my life. And I think spouse and other people in the family would also be thinking something similarly. So there is like a shock or even a real resentment that can come up about like, why me, why now? And then, yeah, I mean, maybe they have kids in college. They're still needing to work, they're still needing to be productive, or that's like a major part of their identity or what they do. And so there's a lot of worry about what's going to happen down the road. There's worry about, will I see my child get married? Things like this that maybe come up when you were seeing your life as having a kind of a long span ahead. And then this diagnosis gets given to you.
So do you think that we need to play a role of reassurance, because all those fears are a little bit unrealistic, right?
Yeah, I think that's part of what I have to do sometimes. I think people hear the label, and again, I know I keep coming back to this, but this has a meaning to people that may or may not reflect how the disease really goes. And some of the work that we have to do is looking at what this is realistically could be like or not.
Yeah, and I think that's a really important message that that I find all the time, that most patients have an unrealistic view, particularly early in the diagnostic course of this, of what Parkinson's disease is and what it isn't. And we're often faced with a period of reassurance that patients can live very well with Parkinson's, and that's why we're having this discussion today, because these are the things that can really impact quality of life. So I'd like to turn now to treatment, because I think the important message to patients and their families and caregivers is that depression is a very treatable condition in Parkinson's disease. It's very important to recognize and treat. And Dan, what are some of the treatment approaches? We as neurologists are uniformly bad at treating depression. We'll often introduce an antidepressant, but don't use adequate doses. We'll stop at one therapy and then turn it over to you. So why don't you tell us about some of the ways we should approach patients with depression?
Well, I think the two general approaches to treating depression involve psychopharmacology or medications and or psychotherapy, and Rachel can speak to the psychotherapy. And can be used separately and they can be used in combination. In terms of the medication management, I agree with you that I think neurologists aren't really trained to use antidepressants, and they don't really have the time to adequately assess or treat depression in many of their clinic visits. There's just not adequate time to cover the motor and non-motor symptoms. But in terms of antidepressants, the main point I want to make is that over the past 5 years or so, we've had several randomized clinical trials that have really demonstrated the efficacy of a range of antidepressants for depression and Parkinson's disease. We have some evidence for older antidepressants, newer antidepressants. We also have evidence that some of the Parkinson's medications can even have antidepressant effects in particular patients. So I think the landscape in terms of the medication management of depression in Parkinson's disease, it's much brighter and clearer than it was years ago.
You agree with that? And how might you approach patients that you see, since you see a lot of patients with depression?
Yeah, I absolutely agree with that. And I think that medications and psychotherapy can often work really well together. It doesn't have to be a one or the other type of thing. So some of it, again, is spending time talking to the patient about what's going on. Medication may be a way to get reasonably rapid symptom relief, which can go a really long way and maybe all that's needed. Helping somebody sleep better, helping somebody feel more interested in their daily life, concentrate better, feel less sad, cry less often, things like this. But often there's other things that come along with the diagnosis of Parkinson's disease, like I'm really worried about my future, or like what if my children get this, or I've been fighting with my spouse ever since this diagnosis came up, or something like that, or I'm worried about planning my retirement, sort of thinking about retirement now that I have this diagnosis. I mean, there are also like problem solving that people may want to do, and psychotherapy can be helpful for that as well. And we should probably mention, in addition to these main modalities, would be other things like support groups, taking classes, or there's even apps that you can use to work on things like mindfulness or meditation, which can help people feel better in the moment.
And you mentioned exercise.
And exercise.
Exercise can be
Good old
hugely
exercise, right.
helpful for both the motor and non-motor and depression.
Right.
So the message here is that depression is common in Parkinson's disease. It's important to recognize, because the symptoms can be subtle, can affect your quality of life and sense of well-being, and most importantly, it is treatable. So don't be afraid to bring this up with your physicians because it is eminently important for your quality of life.